And enough time patients will come to you and say, the doctor told me that I have prostate. All men have a prostate. So the prostate is a small gland, the size of a walnut, in the lower part of the abdomen, in the what we call the pelvis. It sits just under the bladder and in front of the rectum. And it serves some purpose.
Roy, tell me, what purpose does a prostate gland serve?
Hello, thank you as well for inviting me to speak and on this panel. So the prostate, the main function is to produce fluid to sustain the sperm when it goes for a swim to find an egg. So the fluid that you get that comes with the sperm has a lot of zinc, a lot of glucose, a lot of sustenance for the sperm to keep it alive until it goes on its hunt to find an egg to fertilize, and then you have the beginning of life. So the prostate has a very important function in terms of life, you know, and just like any organ, it can develop cancer.
Okay, thank you very much. Back to you, Leroy. So what happens to the prostate as we get older? We need another mic up front.
Well, as a man gets older, the prostate grows. Once a man reaches puberty, then there's a surge of testosterone. So the prostate naturally grows, and as Dr. McGregor told you earlier on, it's now able to play its function more and more as a man gets older. But then comes a time now when the man reaches a certain age, and women go through menopause. Men go through some form of pause, but we call it andropause. All right? No, it's not womenopause. It's andropause. And, you know, there are changes. The testosterone level falls. Testosterone is produced by the testes. But even though the testosterone level falls, the prostate somewhat becomes very sensitive to testosterone. So the prostate grows as a man gets older. And as it grows, it's able to create problems. And there's a risk that cancer may also form in that prostate gland.
Thank you, Leroy. Roy,
Testing one, two,
what
three.
are some of the symptoms that a man may experience as his prostate grows? Or how do you know that your prostate is growing anyway?
Well, that's a good question. As the prostate, so basically, imagine that you have your bladder, which is like a balloon that stores the urine. And then from the bottom of the balloon, you have a straw. And it goes through, so a walnut is same as a lime, a small lime, so the prostate is about the same size. And imagine that the straw goes through the middle of the prostate from the balloon and then comes out through the end of the penis, right? So the prostate, when it grows, it can grow outwards around the tube that you pee through. And in that instance, you have no symptom. And the other thing to bear in mind is that for prostate cancer, the cancer normally occurs in the skin of the lime, away from the tube that you pee through. So early prostate cancer has no symptom, which is why we advocate screening. Now, as the prostate grows, imagine that the lime starts to bulge and squeeze the straw that you pee through. And so just like a hose, if as you step on a hose and you squeeze the tube, eventually you get to a point where you can't pee. So one of the first symptoms is that the stream begins to slow down. And so, when you first pee, when you're young, you can pee and it go, a couple
Skip
feet ahead. Right? And then as you get older and obstruction happens, the pee begins to tail off and you can't pitch it as far as you could. And then in very, very severe cases, you may find that you're actually stopping and starting. So you can't pee completely. You have to strain and push. A little bit of urine comes out and then it stops. You push a little bit more. So one of the signs is a weak stream, intermittency, we call it, stopping and starting. And then hesitancy, where you have to wait for it to come. Take a deep breath and push. And then at the end, you may find that you still feel as though, although you finish peeing, you still feel like there's something left behind. So those are some of the, what we call avoiding symptoms, symptoms that occur during the actual act of passing your urine.
So back to you, Leroy. Are there any things or any environmental factors that affect prostate health? How can I ensure that my prostate remains healthy and avoid some of the symptoms that Roy described?
Right. A very good explanation, Dr. McGregor. I like that I did the talk about squeezing the straw and therefore making it difficult to pass urine. Now, there are three main things that will happen with the prostate in a man. Inflammation of the prostate, called prostatitis. Anything that ends in itis means inflammation. The prostatitis, inflammation of the prostate. BPH, the prostate just gets big as a man gets older, it gets bigger. And prostate cancer. Those are the three main things. Now, in order to make it's difficult to say because there are different theories as to why the prostate gets bigger. And different theories, as much as prostate cancer is very common, we're still struggling to find out what exactly causes prostate cancer. So over the years, there are things that have been suggested, changes in the diet, and various things, herbal medication and preps. But none of these things have been proven without any doubt that these things will make a difference in terms of what happens to the prostate. There's some genetic component, and we know especially with prostate cancer, it's more common in black men, based on race, age, that sort of thing. So it's very difficult to say what is it that we can do. So we always just say, eat healthy, exercise, do the general things that are healthy for you overall. If it's good for the heart, it's good for the prostate.
I always like to eat my tomatoes because they are rich in lycopenes. What's your thought on tomatoes and lycopenes? Roy or Leroy?
So, what was that? So lycopenes are found in tomatoes, watermelon, and so forth. But there were several studies which looked at correlation between lycopenes and prostate cancer. And they found that there was a reduction in prostate cancer in people who had a high intake of tomatoes. But the evidence for this is conflicting. So some studies found that there seemed to be a protective effect, and others found that it didn't seem to make any difference. I come from the philosophy, treat for the worst and hope for the best. Nothing wrong with tomatoes. So, I think, as Leroy said, a balanced diet, including a lot of vegetables and stuff, and having tomatoes in that diet would make sense. It's certainly not going to hurt you.
Thank you very much. I know there's a question from the audience. Carlo?
Actually, not a question, Dr. Little. I'm advised that at the beginning of the program, there was no sound online, so the folks online did not get the benefit of hearing who you are speaking with. So I wonder if you could just give half a minute to introduce once more for the benefit of the folks online.
Oh, certainly. So this evening, we have two consultant urologists. We have Dr. Leroy Harrison and Dr. Roy McGregor, both distinguished consultants in the field of urology. Dr. McGregor has a special interest in minimal invasive surgery, and Dr. Leroy Harrison has a special interest in sports medicine as well. And so we're very happy to have both of them with us, and they're going to give us unique perspectives on men's health and prostate health. So we were talking about prostate health, and we mentioned tomatoes and conflicting evidence. Are there any other things out there where there is conflicting evidence as to whether it helps with prostate health or not?
Well, people talk, commonly there was a big argument about the ackee, Jamaican ackee, and I deliberately bring this up because almost invariably every time we give a talk, somebody asks a question about ackee, and the evidence is not strong that ackee actually is, in my opinion, very healthy. It's plant fat. All right, and there was this argument also about deep sea fish and omega-3 that you get from deep sea fish, and we know omega-3 is good for the heart, good for the cardiovascular system, and it was thought to be good. But again, just like Dr. McGregor says, you have conflicting studies. Some studies will show that there's great benefit from this. There are other studies that show that it doesn't really make a difference. However, I agree with Dr. McGregor in saying that it is still healthy food, so it won't hurt to ingest these things.
Thank you. So, Roy, as Jamaicans, there has been a focus on prostate cancer, and I'm told that the incidence of prostate cancer in Jamaicans seems higher than in other populations. Is this true, and why might this be the case?
Just before I answer that one, just one other thing we should say about diet. There is a correlation between animal fat and prostate cancer. So in particular, red meat. So you should try and reduce your intake of red meat. Chicken and fish is good, right? But fried food on a whole is not good. And so you should steam or grill the fish. Red meat should be lean, and you should eat it as a special occasion, and dairy. There is a correlation between dairy and prostate cancer, and so you should try and not drink or eat dairy product, ice cream. And if you saw the amount of sugar that went into ice cream, you wouldn't eat ice cream. Ice cream is just dairy, double cream, and tons of sugar kind of mixed up and frozen.
So it sounds like a plant-based diet is beneficial for prostate health.
Absolutely. So a diet high in vegetable intake, low in animal fats and dairy is what we would recommend, which is what Leroy said in terms of what's good for the heart is good for the prostate. So that's really, I think, an exercise. So obesity has been related to prostate cancer, but that, again, is controversial. But certainly regular exercise is negatively correlated with prostate cancer. So these are the take-home messages. So in terms of what you had asked about Jamaica and incidence of prostate cancer, basically there is a strong genetic predisposition to prostate cancer. And people from African descent have a higher risk of prostate cancer. So that is, people in Africa, Afro-Caribbean, Afro-Americans, we have a higher incidence of prostate cancer. And people with a family history, the more relatives that you have, especially first-degree relatives, the higher the incidence of prostate cancer. So by just being Jamaican, most of us have some African heritage, right? And so just because of that, we are all in a higher risk category. And that's why the Jamaica Urology Society and the Ministry of Health and Wellness recommend that we screen in Jamaica, because from the age of 40, in some countries, they don't recommend screening. In some countries, you start at 45 or 50.
Okay.
If I may add to what Dr. McGregor is saying in terms of the genetic component. So it's not just having a family history of prostate cancer, but men, if there's a strong history of breast cancer as well, or even cancer of the ovary, the uterus, it means that there's a genetic link. It means that if quite a few women have breast cancer in the family, it means that the men in the family are also at risk for prostate cancer.
Thank you very much. I think there is a question.
Oh, afternoon, gentlemen. Just a quick question. I wanted to go back on the comment that was made about the lycopene in tomatoes and the fact that it's inconclusive as to whether or not it is beneficial. But I wanted to clarify whether or not eating raw lycopene versus raw versus cooked tomatoes, what's the benefit therein? Because I understand it has to be cooked for the lycopene to be active. Is that true?
That is my understanding, that you, in order to release the lycopenes in a form that's easier to absorb, it's better to have it cooked.
Okay, and then the next point is that you made a comment around the connection between heart health and prostate health. Could you expand on that thought so that it could benefit persons hearing, and touch on possibly more about the plant-based benefits, which was suggested just now, because I mean, as a faith-believing group, plant-based diet is something that we promote, so some of that, we'd love to see some of that feedback here.
All right. So it goes right back to what we were saying, that the evidence in terms of diet and what diet is beneficial for prostate cancer is not overwhelming. Dr. McGregor pointed out earlier on about certain things that can be eaten, that sort of thing, but studies, let's say half the studies show benefit, half the studies don't show any benefit. So it's not conclusive, but what we do know in general is that plant-based diet is really better than animal-based diet. Because in the reign, even in the reign of animals, you know, there's a lot of hormones, a lot of antibiotics, you know, and the animal fat is rich in cholesterol. So that in general is not good for our cardiovascular system, our heart. It puts us at risk for heart disease, stroke, that sort of thing. So plant-based, you cannot lose with plant-based diet. So that's really the benefit, because the evidence suggests that diet will really improve your risk, prevent you from getting prostate cancer. It's not overwhelming. But we do know that the plant-based diet is good for you overall, in general.
Thank you very much, Leroy. So you mentioned screening, and screening and the recommendation that screening start at age 40 in our population. Can you tell us, what does this screening entail?
So screening involves, first of all, it's between the age of 40 and 75. Those are the guidelines, but you know, I just need to make you realize that those are still guidelines. Okay, so you may have someone who is a fit farmer who's 75, but biologically he's more like 68, and really it's you need a life expectancy of greater than 10 years to warrant screening, because prostate cancer on a whole is slow growing. So in order to benefit from the treatment, on a whole, you have to be able to live 8 to 10 years before you start to see a benefit from the treatment. So between 40 and 75 is the age, and it involves a blood test to look for something called the PSA, which is prostate-specific antigen. And this blood test is, on a whole, high in people with prostate cancer. And then the other is a prostate exam, where the physician examines the prostate and feels the prostate to see if there are any hard, irregular areas that are cancerous, associated with cancer. And so usually the screening involves those two tests, the blood test and the prostate exam. But recently, certainly in countries, in first world countries, they are now saying that you can just do the PSA. But, and I'd be interested to hear what Leroy what his views on this are, because our population, you know, really we are high risk, and so we should screen, first of all. One little thing about PSA is that in about 15% of prostate cancers, the PSA is normal. So if you're relying on the PSA, you're going to miss this group of patients. And the other thing is that, you know, when you have high-risk prostate cancer, right, the more aggressive the cancer is, actually the less PSA it produces, right? What happens is the cancer grows in an irregular manner and it leaks the PSA into the bloodstream, and so the levels are high. So I would still, although it is debatable, I would still recommend PSA blood test and the prostate exam. And you put the two of them together and it increases the pickup rate. So if you have either or both, you should then go to have further investigations to see if the patient has prostate cancer.
Okay. I want to spend a little time on the rectal exam and the PSA. So, Leroy, how specific is the PSA? Roy indicated that there are some patients who may have prostate cancer with normal PSAs. And my understanding is that there may be persons without prostate cancer who have elevated PSAs as well. So tell us a little more about the specificity of the PSA test.
All right. So the PSA, as Dr. Margus mentioned earlier on, this is a substance produced by the prostate. So the normal prostate produces PSA. As the prostate gets bigger, the bigger the prostate, the more PSA it produces. So it produces a certain amount per gram, per weight of prostate. If a man develops prostate cancer, it produces more PSA per weight than even a normal prostate. But as he mentions, there are some cancers that are so aggressive that they barely produce any PSA at all. So in screening, and the whole purpose of screening is to detect the cancer long before it manifests itself in terms of symptoms. But cancers in general, whether it be breast cancer, cancer of the cervix, the kidney, whatever, most cancers will not cause any symptoms when they are early. When you start having symptoms from any cancer, it means that the cancer is fairly advanced. So they have developed ways and means to detect the cancer. So with screening for prostate cancer, we can detect the cancer 5, 6, 7, and in some cases up to 10 years before that cancer would have been a problem. So as he says, the more aggressive the cancer, the PSA probably doesn't change at all. So if we rely on PSA alone, we might miss, say, 15%, as he says, of patients who will have prostate cancer. And I know of a case recently, a man who was diligently doing his PSA, and he continued up in his 80s, probably didn't need to, up in his 80s, and his PSA remained quite normal. And then all of a sudden it made a sudden jump. And when the doctor went and checked, he had prostate cancer. Probably if he was doing the digital rectal examination as well, they would have felt it even while the PSA is normal. So if you have to do only one test, it's really the blood test. But 2 in this situation is better than 1.
We have a question at the mic. Go ahead.
Good evening, gentlemen. What I want to ask is that is there any proof to say that because this theory that men who sleep with more than one partner are prone to have prostate cancer than men who sleep with just one partner? And there's another theory that having sex regular or frequently then, in whatever, it's prevented men from having enlarged prostate. And seeing that is the enlarging of the prostate that's causing, is there any medication that has been developed to shrink this enlargement?
All right, we'll share the answer to that question. That's a good question. There are 2 studies which looked at the frequency of ejaculation, but they were all in younger age groups. And it did say that if it was above 21 times per month, there seemed to be a reduction in prostate cancer. But it didn't seem to translate to older groups. And the other thing is, a few studies have looked at frequency and, is there a difference between people who are married, right, and people who are not? And that didn't seem to play out. So just unfortunately, like a lot of these things, it does seem to be controversial. I think there is a slightly increased risk with prostatitis. So if you have infection of the prostate, there does seem to be a slightly higher risk of developing prostate cancer, particularly with a certain organism, trichomonas. But I think on a whole, certainly when you're treating prostate cancer, it's good to flush the prostate on a regular basis just to help to clear things out. And I think that's probably, the benefit that you're getting from it. And, a lot of these, especially if there's bacteria, when you flush it, when you ejaculate, that gets rid of it. If there are any carcinogens in the semen from stuff that you consume, you're getting it through the system. So I think a good part of prostate health is, active, healthy sex life, But I can't really, I think that's basically the limit of the information that we have on that.
Yes, because the frequency with which a man would have to ejaculate is just most of the young men would be able to do that. And probably
21 times per month.
And the older men who are more at risk because it's age-related wouldn't benefit, they would probably get fatigue. Anyhow. But with regards to size, and yes, the infection, there has been some evidence, but it seems to be more with, especially with sexually transmitted infections of the prostate. But with regards to size, so when patients come to us and the prostate is big, that is not what is alarming to us as doctors. As Dr. McGregor says, if the prostate is big, but it's expanding outwards and not squeezing the urethra, that little tube, straw as he describes it, and not causing it to have any symptoms, we're not worried about the size. What we're worried about more so than size is the PSA that it is producing, because the prostate, as a matter of fact, a lot of the patients with prostate cancer don't have very big prostate. So the prostate can be normal size, but it's producing a lot of PSA, which is suggestive that there may be cancer in it. Yes, there are drugs that you can use to shrink the prostate, but we don't routinely give men that drug. It's called a 5-alpha reductase. It reduces the size of the prostate. And we usually use it for men who have large prostate, who we think do not have prostate cancer. But you wouldn't give it to somebody who has a large prostate but not having any symptoms because it has side effects, especially with sexual dysfunction, that sort of thing. So you wouldn't routinely give it. So, yes, there is drug out there that can be used, but it's not recommended to use it for the purpose of preventing prostate cancer.
There's a question, Carlo.
Yes, well, not really a question. I'm relaying the information as it comes online. Yeah. But let me just state for the record that 21 is my kind of stats. Anyway, some persons have just recently joined online and are asking us to repeat what PSA stands for.
So PSA is short for, or an acronym, is prostate-specific antigen, PSA, and it's a protease, so it's like it's a protein that liquefies semen. So when semen comes out, it's normally clumpy, and the PSA, the prostate-specific antigen, it digests the semen to make it more runny. So But that's the actual physical function of that.
Right. So let's say one of the gentlemen in our congregation decides that he wants to go and get his PSA done on Monday morning. Are there any instructions that the person must take into consideration before getting the PSA test done?
I can answer. I always tell people to not ejaculate for more, I usually say 2 to 3 days prior, and not to ride a bicycle for 2 to 3 days prior. Because both of these actions can cause the PSA to go up. And I do have a patient, and I tell this story all the time, that he came to see me and he had had a PSA which was going up and down, and he'd had his prostate. So if you think someone has prostate cancer, the way you make the definitive diagnosis is to get tissue from the prostate, which we do a prostate biopsy. And it does involve putting a probe up the back passage, ultrasound probe, and then passing a little needle down the probe to get tissue from the prostate. It's not the most comfortable exam in the world, right? And it has certain risks. Anyway, this patient had had his prostate biopsied 3 times. And when I was chatting to him, I said, "Do you ride a bicycle?" And he said, "Oh, I'm president of the cycling club." And so we got him to stop riding a bicycle for a week, repeat his PSA, and it went from bouncing around at 12, 13, 14, down to 2, right? And a lot of it also depends on, I think in his case, he had a big prostate, so when you sit on the saddle, it was affecting the prostate. And he used to ride marathons, you know. So it's also correlated to the size of the prostate. If you have a small prostate, bicycle riding doesn't have as big an effect as if you have a large prostate. So those are the 2 things that I would normally say.
You asked earlier on about the PSA being the specificity of the PSA. Now, the 3 main conditions I mentioned earlier, inflammation, large prostate cancer, all 3 will increase the PSA. All right, but we also look at the rate at which the PSA increases. So not just the final result, but if you're doing PSA over a period of time, the PSA might remain normal throughout all that time, but with that also the rate at which the PSA climbs to determine whether there's a high risk or suspicion of prostate cancer.
So in the course of regular screening, let's say a guy in their 40s, average risk factors, how often should a PSA test be done?
All right, so in Jamaica, we have internationally there are recommendations, but in Jamaica, what we have adopted is we use age 40. We start at age 40, do the screening every year, and we go up to age 75. But that 75 can be adjusted, as Dr. Maria says, depends on the state. And if the patient has like very bad heart problems, and the chances of them living another 3-4 years is very slim, we're not really interested in finding out if they have prostate cancer, because they're not going to treat it. The treatment is going to be worse, kill him faster, you know? So we use that to determine, you know, when we do the test. Now, the thing about it is that, as I say, in terms of age-related, no, because in North America, Europe, they'll make recommendations, and sometimes they'll start at age 45 or even 50 in some settings. But then you have to remember, our population is at greater risk. They are predominantly a black population, and that population is a mixed population. And even that mixed population, they may isolate different groups. So for white Caucasians, they may start at 45, 50. But if that white person has a family history, they may start at 40. So there are different factors that determine how fast. But it can be a bit confusing, so we just keep it simple here in Jamaica. Start at age 40. Now, if the PSA is very good, sometimes they'll say, okay, you don't need to do your PSA until 2 years' time. But the problem is, some of our men, we give them 1 year, and you don't see them until 5-6 years. Can you imagine if you give them 2 years? You might not see them until 10. So we just keep it simple. Start at age 40 and come yearly to do the test.
Thank you very much. Dr. Little, question from you.
Yes. Because we're talking about doctors, I'm not one of those doctors. I am processing the information, and I am sensing that there is a correlation between elevated PSA, prostate size, and prostate cancer. But I'm not hearing that there is a causal relationship, and maybe there isn't. So my question would be, have we been able to identify, specific causes of prostate cancer? Because size, I'm understanding that size is not the best. As a standalone, size is not a good indicator as a standalone. PSA as a standalone is not a good enough indicator as well. So you combine those two. But I'm also understanding that even when you combine those two, the results might not be conclusive. And so you get into doing that brutal, almost slave caveman kind of a biopsy. It is brutal, having done about 5 or 6 of those. So what are the causes that we can manage?
Causes of prostate cancer?
Yes.
Okay.
So there's still a lot we are learning about prostate cancer, just based on the very heterogeneous nature of the disease. And you're right, the PSA is still the best indicator in terms of trying to diagnose prostate cancer. So over the years, the range has sort of changed or fluctuated a little. It was said that we should use 0 to 4 as being normal. Then there are some places now, like in Europe, North America, they're using 0 to 3. Now, there's no PSA at which you can say a person does not have prostate cancer. It's all about what are the chances, the likelihood of this patient having prostate cancer, depending on what the PSA measurement is, even irrespective of the size of the prostate. So yes, a big prostate will account for higher PSA, but still at the same time, PSA over a certain range, irrespective of size of the prostate, will put you at risk. So for example, PSA less than 1 nanogram per mil, as much as 8% of patients have been found to have prostate cancer. When you move now from 3 to 10, as much as 25%, 1 out of every 4 patients with a PSA between 3 and 10 will have prostate cancer. When you go beyond 10, as much as half to 2/3 of those patients will have prostate cancer. But a patient would say a prostate of 200 grams, based on what we call PSA density, may have a PSA of up to 30, and it's just due to sheer size. But we're not sure, because the patient has a large prostate, and part of that is just increase in size, BPH, due to age. But that patient in that same prostate may have 10% of that prostate having cancer. So the PSA that he's producing, how much of that PSA is due to the cancer? How much of it is due to the BPH part, just a large prostate? It's difficult to say. So we just use certain parameters and use certain range and say there's a likelihood. It's better to check you out. It may end up being an unnecessary biopsy, but because this thing is so common and prevalent, let us just do the biopsy.
Just to add to that as well, it's not as brutal these days because we use lidocaine, so we can actually, prior to the biopsy, inject local anesthetic into the prostate, which makes it a lot less traumatic. And PSA, although it's not perfect, it's a pretty good tumor marker as far as tumor markers go. And the the cutoff level of 4 is chosen because you don't get too many false negatives, and you don't get too many false positives. Because what you don't, if you keep going lower and lower, you're going to pick up, more cancers, but you're also going to pick up people who don't have cancer. And you then get the worried people who get stressed out because they think they may have cancer, and then they end up having unnecessary biopsy. So it's a kind of sensitivity, specificity thing. And we've kind of, at one point it was 6. And you would detect, almost everyone you would detect, or there'd be a much higher positive rate at 6, but you would have a lot of false. You would miss a lot of cancers, right? So 4 is where it's at. And yes, PSA can, I think the highest PSA I've seen because of infection was 200, right? So I had a patient who had acute prostatitis, and the PSA was 200. He came to me as a known diagnosis of prostate cancer. And we checked the PSA, it's 200, but he had burning when he peed, and he had pain on ejaculation, and the prostate felt boggy and it was tender. We gave him a course of antibiotics, went back and repeated the PSA, and it came back down to 2. Right? So that was a very happy patient. I got to say, I haven't seen many PSAs go up that high. Usually it's like 40 or 50 or so forth. So that was unusual. But, once you screen for infection and you make sure that, and they're not riding a bicycle and they haven't ejaculated recently and so forth, the PSA is not bad. And you combine it with the rectal examination, and it's pretty accurate.
All right. Just want to suggest that perhaps urologists might want to get a little more involved in the design of bicycle saddle. Just say.
Before, because you had asked something about cause. It's not really the etiology, the cause you were asking, but since you asked about some causative relation and all of that, as I said earlier on, we're not sure as to the cause of prostate cancer, but I'll quickly tell you that eunuchs, eunuchs. Yes, eunuchs do not get prostate cancer. That's what has been shown. All right, so if a man is castrated from early, whether it be cultural means or whatever, he doesn't get prostate cancer. So testosterone, we know, drives the growth of prostate cancer. We can't say that it causes it, but if the cancer is there and the testosterone is there, it drives the growth of the prostate. Now, when they do autopsy on all men from all races, the incidence and prevalence of prostate cancer is the same in all races. In other words, if you take black, whites, Asians, and you do autopsy on them at age 90, take out the prostate, the cancer is equal amongst all of them. But while they're alive, for some reason, black men manifest it more, followed by whites, followed by Asians. It is suspected that there may be a dietary factor involved, because Japanese who are in Japan have low incidence of prostate cancer. But if they move over, like to the United States, to California, and they marry to Japanese, so they keep the gene pool amongst themselves, they have a higher level of prostate cancer than Japanese who remain in Japan. What has changed? The diet. They come over and they eat the Western diet. But with black men now, they have been shown to have a higher level of testosterone than the other races. So could it be the testosterone that's driving it? So it may not be the testosterone causing it. They are predisposed for one reason or another, but the testosterone precipitates the onset of the cancer.
I would love to see, though, for my Jamaican colleagues, that we're able to rule out Aki as a cause. Aki is perhaps the best, the best plant fat around, and I certainly don't think that it contributes.
If you're willing to fund a study. Or Pastor. Yes, go ahead, Pastor Oliphant.
Firstly, good afternoon, and thank you all for this enlightening session. I want to first point out that there's almost 2 women to each man here today. I think that's indicative as to the work that we need to do. I stand here as one who has, not proudly, but my doctor says I have to do it, so I do it every year. I do my executive and the digital rectum, which I know a lot of men are uncomfortable with, but, but given the fact that it touches health and life, I think I would like to hear from the panel, what is it that can be done to help us in our Jamaican context to deal with that? The second thing I would like to ask about, because I've been hearing for years about the magic age of 40 to start the screening. However, I am aware that individuals younger than 40 have been diagnosed and even died from prostate cancer. Could you explain how that anomaly can work out in real life for individuals who maybe already be by genetics, family history, etc.? How do you do that intervention? And thirdly, I am happy to hear, and I was with my wife at the time when I heard the 21 days. That is a good sound for a 30-day month. 21, that's very good. I am asking the other side of the question, though. What about, how does it impact sexual intimacy when one actually has prostate issues? What are some of the signs individuals should look out for, and how does it impact it? So those are my 3 questions.
3 big questions.
So like about 4. All right. I think the first one was about getting the men to comply to do the digital rectal examination. Interestingly, because our urologists go to the Jamaica Cancer Society to do screening to assist them as volunteers. And I remember a young policeman came in and he did his PSA. And when I said, okay, sir, just go over here where I can do the rectal examination, he was, hesitant and twisting and turning and didn't want to, get undressed for me to do the rectal. And then he hissed his teeth and said, Doc, there's only one reason why I'm doing this test, because the wife threatened me and tell me if I don't go get myself checked out and I get prostate cancer, she wouldn't even look at me. So that's why I'm happy when women are here, because you are much stronger and more influential than you think. Just go and threaten that man. Because men love to brag that they are 50, 60, 70 and they have never gone to a doctor yet. And I say this to them, it's not the first time leaf drop of water, but it's rotten. Mm-hmm. And the question I ask a lot of them is, do you drive? And they say yes. Do you wait until the car is giving trouble? You go and check it out? Or you service it periodically? I get the point, Doc. So they get the message that you don't wait until you start having symptoms. You go and get it checked. And, a lot of them, after they do the rectal examination, they'll turn to you and say, Doc, is that simple? They can't believe it's that quick and simple, because based on what they were thinking, they think it's... One patient thought, when we said digital, he was thinking of analog versus digital. So he said every time he went to his doctor, the doctor didn't just look at the PSA and examine him, but didn't do a digital rectal. So somebody asked him, and he thought it was some digital device that they were going to push up in the rectum. So,
Leroy, for that purpose, we're going to get back to your questions, Pastor. But Leroy, just quickly, for any of the men who may be here or online who have never had a DRE done, quickly tell us what to expect. How quick is it? Tell us.
All right. It's literally less than a minute. So we get the man undressed, put him on the bed, or sometimes he can stand by the bed and, bend over. But more often than not, he's lying on the bed, lying on his left side in what we call a fetal position, curl up. All right. So we quickly inspect the area and we use well lubricated glove fingers. So we have on a lot of lubricant on our finger, and we just ask the men to relax. The thing is, the muscles at the anus, they are normally closed to prevent stool from falling out. So when we're going to examine the men, we want them to just relax. The problem is a lot of them are tense. So it's like you're pushing against a closed door. So we just ask them to relax, and then we gently insert the finger and examine the prostate. It's not painful, might be a little uncomfortable, but the thing about it, some men, it may be a little bit more uncomfortable, especially if they have inflammation, like the patient Dr. Merrill talked about. If the prostate is inflamed, it might be a little bit more tender than normal because something is wrong with the prostate. But most of the time, it's not. Few seconds, and it's all over.
Thank you. Roy, you want to take on a second question?
What was the second question again?
The age issue, the 40,
Screening
the
at 40. And persons younger than 40
younger.
Having prostate cancer.
Okay, so that is a very good question. And you always have outliers, right? So you have a standard distribution, right, which is like a bell-shaped curve of frequency versus, so at the bottom you'll have, you know, the age of the person. And the majority of people are clumped together in their 60s, right? That's the usual section, the average is in your 60s. And then, you will get people who get it in their, prostate cancer is a bit different in that the older you get, the more likely you are to have it, right? But the peak, the age at detection or presentation is like in the 60s, 70s. So, but you will get people in the extreme early ages that develop prostate cancer, but it's not common. And what you have to do as a government or a Ministry of Health, right, and you have limited amount of resources, you would have to, if you started screening everyone in their 30s, you'd have to screen one hell of a lot of people in order to pick up your one patient, right? And so you can't afford to do that, and it's not cost effective. But Leroy mentioned earlier that if, however, you have a patient, because this person who was 30-something that had prostate cancer, I'm sure he had a family history, right? Mm-hmm. And that there was at least one person in his family who had prostate cancer as well. So, for someone who doesn't have a family history of prostate cancer, we wouldn't recommend going below 40. Okay. Because you end up screening a whole load of people unnecessarily so to pick up that one person. Not that the one person isn't important, right? But it's better to target someone. So if they have 4 brothers with prostate cancer and he's in his 30s, and his PSA may be less than 4, but let's say it's 3 something, which is kind of high for your 30s, right? We normally say if the PSA is 0.5 or less in your 40th decade, even if you have a family history, your risk of developing it is that of the normal population.
Okay.
Right? So I don't know if that answers the question completely, but you target, you would screen someone under 40 if he was high risk, multiple risk factors.
Okay.
Right? But you wouldn't recommend it for everyone. You wouldn't drop your screening age just because you got one patient who out of, so many that has prostate cancer.
Understood.
Yeah.
What was your third question, Pastor?
My third question, sir, was in relation to the 21-day. I like that number, the 21. That's sounding good. But I'm really, those individuals who may...
How does it impact? How does prostate cancer impact?
Impact your sexual health after. What are some of the signs, the symptoms that individuals should be looking out for, and how that can be improved?
So if you have... Are you asking about someone who may have prostate cancer and they're not sure what effect it could have on sexual function?
Yeah. So I'm going against the backdrop that Because the males are not going to the doctor and doing these
Right,
screening.
so they've got prostate cancer. How could it affect your
sexual
health?
function? And if there are symptoms they can look out for.
Okay, that's a good question. On a whole, it wouldn't really affect sexual function, right? So I'm just thinking about this. At best, even if it's involved in the nerves, let's say it's, because the nerves that run to the penis, there are two of them run alongside the prostate. And so, it could be that the cancer is invading the nerve, but even then, so you may get a slight reduction in erectile function, but that's late stage. Usually it has no effect.
Okay.
And even like blood in the semen, usually blood in the semen is not consequential. It's not correlated to prostate cancer. You may see it, but usually it's not associated, right? It's more likely infection or so. Okay. So on a whole, prostate cancer does not affect sexual function. Okay. The treatment of prostate cancer, if you don't screen and catch it early, can affect your nature. And so one of the reasons that you screen is that if you catch the cancer early, you can do a surgery, for example, and spare the nerves, where you leave the nerves behind. But if you wait until the cancer has progressed and is involved in the nerves, then you have to take the nerves with the prostate.
Okay.
Yeah, I agree with him 100%. It's not the cancer that affects the erection. It's a treatment modalities that can interfere with the sexual function.
Very well. Thank you.
There was a young man who was at the mic. I think he sat down out of, it's okay? Question was answered.
I am very glad that you are talking about early getting the cancer early, that the treatment are less extensive and you could spare the nerves. I have two relatives who were diagnosed with prostate cancer. And both of them, their PSA has never been above 4. Never have been above 4. They were diagnosed with normal PSAs. Normal PSAs. And I want to just interject here about this sparing of the nerves. These two people who were diagnosed with prostate cancer, it was caught so early that they did not need surgery. And you'll come to the treatment later. They did the radiation treatment, the radiation treatment, and then they didn't need surgery because it was caught so early. And this is over 20 years, and they are still alive and having no prostate issues. So if it is, so, and the prostate, the rectal examination, the digital, is what picked it up. Because the PSA was low, but the doctor still felt when they did the rectal, they were feeling something, they weren't sure. And so let's go ahead and they actually did an MRI as well, and did the examination, the digital, and did the biopsy and found the prostate cancer. So there is a lot of merit in getting both the rectal examination and the PSA done, because you can catch it more early, as you said, and the PSA does not have to be elevated. I know it was mentioned, but to reinforce it, the PSA doesn't have, and I have living proof. I have 2 uncles, and they are still alive after having been diagnosed over 20 years ago with prostate cancer with PSA that was low.
Thanks, Dr. Cornell. Young man at the mic.
Good evening, everyone. So you spoke about family genetics. So my question basically is, are there any early detection genetic tests that could be done to pick up prostate cancer?
Good question.
Yeah, there are genetic tests, but it's not done routinely, right? Because in truth and fact, it's only about 10% of all the prostate cancers that has a genetic component or hereditary factor to it. It doesn't mean that the other 90, it could be more. It's just that sometimes, especially in Jamaica, where a lot of men don't know nothing about the paternal side of the family. So it could be that there were some genes coming down along. But if, for example, there members of the family, like females, had breast cancer and so on, ovarian cancer. Yes, then the men know that they are at risk, as I mentioned earlier. So there is genetic testing that can be done to say, do I have this gene? Do I have the BRCA1 gene, the BRCA2 gene? That can help to determine, if I am at risk, greater risk than the normal population.
Okay, thank you.
So I want to pick up on a question. I want to pick up on something you said earlier, Leroy, about post-mortem examinations and high prevalence of prostate cancer across ethnic groups. There are some persons who are of the impression, and there's a lot of stuff out there in social media, that a lot of persons will die with prostate cancer, but not necessarily from prostate cancer. And this same group of persons will posit that we are being a little too aggressive in terms of screening and treatment of prostate cancer because it's not killing people. People are dying of other reasons. I'd love to hear your opinions on this, Roy and Leroy.
All right. It's like you open a can of worm there. And it's a big question. And here's my thought process. And Dr. McGregor alluded to it earlier on when he spoke about shifting the age. That's why we are also careful as to what age we start screening. Because as he said earlier on, most patients who will manifest with prostate cancer will probably be in their 60s, late 50s, 60s. But then now, we start screening at 40 because a lot of them will start developing the cancer from in the 40s. But prostate cancer is a slow-growing cancer, and it will take decades to manifest, right? But the lowest, so you'll have to, there have been documented cases of 20-year-olds having prostate cancer, but as Dr. McGregor said earlier on, you'll be if you drop the age to 20, you're going to be screening almost everybody who just left high school, all the males, just to pick up a small percentage of patients. No, but let's look at it. In Jamaica, prostate cancer is the #1 cancer in terms of its prevalence and in terms of it being a killer. More people die from prostate cancer than women dying from breast, cervix, colon, lungs. In the United States, it is the #2. It's the second biggest killer. So even though most men who have it will die with it but not from it, still a large percentage of people are dying from it. Now, I see a lot of, this is kind of anecdotal, but it makes sense. I see a lot of JDF soldiers. And I've never seen a JDF soldier dying from prostate cancer or being diagnosed with advanced prostate cancer. And remember now, it's when it's in the early stages, we can do something about it. And so you not while they're in the army, you don't see them dying from it or presenting with an advanced case. But in the rest of the population, it is the #1 killer. What's the difference between those two groups of men? One because in the army, every year they have to do a medical and a physical to renew the contract, to get re-engaged. The rest of the population, they do not get screened, they don't have to re-engage in anything. So you see the big difference? One is getting keen medical attention, the other one is not, and we can see the death rate between the two.
Any comments on this, Roy?
No, I think that pretty much sums up the situation.
Our population is just different. As I said, the other populations, they are mixed. We're in a population that's predominantly black. Tobago has the same issue. And the black populations in Africa, we are facing, and even America with the mixed population, it's still #2. What may happen is that probably some of the cancers that we are treating, we are diagnosing them, but probably they don't need to be treated. In other words, there's still a lot that we are learning about prostate cancer. So until we know more about it, I believe we should continue to screen.
Thank you. Young man?
How does prostate cancer kill you?
how does prostate cancer kill you? That's a good follow-up question.
All right, so prostate cancer is, so basically, let's just look at cancer. All right, so what is cancer? And cancer is basically a cell that suddenly, most cells when they get to a certain age, they go what we call apoptosis, which is like this programmed cell death. So it lives for a certain amount of time, and then the cell dies, and then a new fresh cell comes up to take its place. And for some reason, cancer cells lose that programmed cell death. And so they start to divide and grow. And the cells go rogue, right? And they start dividing and growing, and they start spreading, right? Initially they grow locally, and so they start killing all the other cells around them, right? And then what happens and what makes it really a cancer is the cell will suddenly spread. So it will jump into the bloodstream, right? Which is like the river. And it will go around the body, and it will jump off somewhere else in the bone, for example. And then it will start to grow in the bone. And so that is the essence of a cancer. It's a cell that keeps dividing and becomes immortal, right? And then it actually spreads to distant areas. And so that is, so in prostate cancer, what happens is the cancer starts in the prostate, it divides and it grows, and it may destroy the tissue around it in the pelvis, right? And then it will spread to different areas in the body and grow and destroy the tissue around it there. And eventually, the cancer just takes over the body. Does that make sense?
Okay, it's enough.
All right.
Did you answer how does it kill you?
Yeah. Let me say, I've realized that we, the African race, or the black race, is affected mostly from this disease. And also that we consume a lot of sugar and a lot of dairy product. Has there been a study to show if these diet, affect or enhance the possibility of prostate and prostate cancer? Consuming sugar and let me say, dairy product.
There are studies, and there are correlation studies. So there seems to be a correlation between red meat and animal fat and a higher incidence of prostate cancer. There also seems to be a correlation between dairy and prostate cancer. So there are studies where they've looked at people who develop prostate cancer, and they tend to have a higher diet containing these factors. And people with a higher diet containing vegetables and so forth have a lower rate of prostate cancer. So yes, there are studies that show or seem to indicate that there is a relationship between diet and prostate cancer. And what Leroy mentioned as well earlier is that what is clear proof that environment and diet is important is that if you take someone from Asia who has the lowest rate of prostate cancer in the world, and he migrates at a young age to Jamaica, his incidence of prostate cancer goes up significantly. So therefore, something has changed with the location, and we think the explanation is diet. Yeah. But, you know, the reason we can't say 100% is correlation doesn't equal cause. You know, because it's like you say, well, boy, the sun rised today and I developed prostate cancer, so it must be the sun coming up that gave me prostate cancer. You know, it's not conclusive, but it does seem to be significant.
Okay, Carlo?
Yes, thank you much. I've been asked to ask this question. I'm just the messenger. Can females carry the rhesus gene of prostate cancer? The person asked because she has males in the family who have prostate cancer, and the only connection is the female. So the question is, can females carry that rhesus gene?
Well, I can't tell you that it's a rhesus gene or a dominant gene. But we do know that there's an association with those genes, the BRCA1, the BRCA2, and there are other genes that are involved. But what we do know is that if certain cancers are prevalent in family members, then it can be carried on. So yes, the same genes, what we're saying, again, it's correlation. The same genes that cause breast cancer, the same genes associated with breast cancer, same genes associated with pancreatic cancers and those cancers, maybe the same genes that are also associated with prostate cancer. So, as Dr. Margot says, a correlation and association doesn't mean a cause and effect. So that is what has not been proven yet. Just like we said that even the dietary factor, we see a connection, but then you have to be able now to reproduce that in a study, you know, in experiments, that sort of thing. So this is the trouble we're having. So even though we say the black men have higher testosterone level, yeah, at the autopsy we see all the races have the same prevalence. So it is theorized that it may be because of that, but it hasn't been proven without doubt. So it's like you see, somebody was found dead in a house, and at the time the police went there was a man running from that yard. There seems to be a correlation with that man, and it may be that he committed a crime. But it does, if you haven't proven it, it's difficult to say that he's the cause of the death.
Yeah, and just to say, so the BRCA gene, right, is a breast cancer, that's a abbreviation for breast cancer related gene. So we do know that people with prostate cancer, they tend to have a mutation in that gene, which is the same as for people with women with breast cancer. So there is we know that there's this genetic association. Just because you have the gene doesn't mean you're going to get the cancer, right? And that's going into something called epigenetics, which is that environment triggers the gene into action. But, you know, if you have family members, first-degree relatives with breast cancer, or multiple relatives with breast cancer, then the males in that family will have an increased risk of prostate cancer, and the other way around. Right?
Okay. I've been asked to ask one last question.
Okay, yes, go ahead.
The question is if a man can pass on the carcinogens to his wife and she might develop, well, I guess it would not be prostate cancer, but I suppose breast cancer. A lot of women apparently seem to have this view.
Are they asking if there's some intimacy, if it can be passed on through intimacy?
Yes, that's what they're asking.
Yeah. No.
Okay.
Well said.
So there are 3 questions online. I'm just going to take the 3 questions online before I come to gentleman at the mic. So can we just look at the 3 questions? What are the signs of prostate cancer? Quickly in a minute. The other question is pork eating, does that increase prostate cancer? And how fast does prostate cancer grow? What's the Gleason score, and what does it tell us? So if we can just attack those questions quickly, and then we'll go to the gentleman at the mic.
Okay, what are the signs of prostate cancer? As I said, we don't want it to have signs. We want it to be screened long before you have signs. But if you should develop signs of prostate cancer, the signs, symptoms and signs are not specific to prostate cancer because the bladder is a poor witness. So large prostate cancer can have some of the same symptoms. As Dr. McGregor mentioned some of them earlier on, the man will notice that he starts passing urine. If it's advanced, start passing urine often at night. We call that nocturia. Frequency, some strong urge. The stream is weak. Painful ejaculation. Blood in the urine. And if it's even more advanced, pain, bone pain. He may have bone pain. It may obstruct the kidneys, cause kidney failure, weight loss, those sort of things. So those are some of the signs. So they're not very, very specific for prostate cancer.
Roy, pork eating.
Well, that's animal fat, right? So there is a correlation. It's not good for your heart. If you do like your pork, then make sure you eat it lean, but keep it to a minimum.
And then the final question, how fast does it grow? And the Gleason score, what does it tell us?
All right, I'll do the grow part.
All right.
Prostate cancer is a slow-growing cancer, but every cancer have what you call a doubling time. So it will grow to a certain extent, it will grow pretty slowly, but then after a while, it starts to speed up. So it as Jamaicans would say, it turns the corner, and then you may see things start happening slowly. So men who are diagnosed like with stage 1 prostate cancer, where the cancer is just confined to the prostate, if you do nothing at all about that cancer, in 10 years, 60% of those men will still be alive. If you do nothing, just to show you all. But if you intervene, instead of 60% being alive, you may have 90, 95% alive. So it's a really slow-growing cancer.
Gleason score? What is a Gleason score and what does it tell us?
All right, so basically when you take a biopsy and you get the prostate cancer tissue, the pathologist will look at it and look at the architecture of the cancer. And the more aggressive the cancer is, the more irregular and haphazard and less like a prostate cell and more like just a generic or just a basic cell of no function. And the more irregular and the more cancerous the cell, the higher the Gleason score. And so if your Gleason score is 10, that's the most aggressive. And those cancers tend to grow quickly, spread rapidly, and are aggressive, whereas a Gleason score of 6, those are very low-risk cancers. They grow very slowly. And so the Gleason score is important in terms of prognosis, in being able to predict how quickly the cancer is going to grow. So a Gleason 10, most people will be dead within, 5 to 6 years. A Gleason 6, most people will be alive in 20 years. So that is a difference. And the majority of cancers are low-risk cancers, and people are more likely to die with it than of it. But what we're trying to catch, and when they talk about over-screening and over-detection, it's picking up these low-risk cancers that weren't going to cause any problem anyway, and you're more likely to die with it than rather of it. We're not interested in those cancers. We don't want to detect those cancers. We want to detect the aggressive cancers, the 7, 8, 9, and 10s, that will go on to cause death. Yeah.
Go ahead for me, please.
Thank you. First, I'd like to start with a compliment of the host. They do not carry a regular Jamaican body type. The regular Jamaican man has more pudginess around the waist. So outside of the room, I'd like to ask them if they would share with me what their prostate cancer status is. I know. Because clearly they exercise a lot. My father died at 100, and he had a ruptured prostate, late life, and it was removed. And he lived till 100. Could you share with the church what the expected sexual behavior and lifestyle would be for someone that has removed their prostate, uncomfortable response? Also, is there a way to prepare the Jamaican national dish so that we can have it and it has less deleterious effect? on the causal discussions or relation to prostate cancer, and then tell my wife. And I have a picture to show the church this evening. It's a very interesting picture. Most doctors speak about their prostate cancer patients. A lot of patients speak about their prostate cancer experience. I like to show the church what the prostate cancer examined patient look like and his doctor. I'm going to ask Dr. Stern to step to the mic and join me. Could you please? This is my doctor for 40 years. And he has prodded and poked every orifice in my body. So he knows a little bit more about this is my doctor. So this is what a doctor and patient examination look like. It's not fake, it's actually real.
Thank you.
Okay. That's what it looks like. So it's not fake. You actually go to the doctor and he prods your body and you're not going to die. And he's not going to kill you. By the way, it ends with prayer every time. So it's, tell me what the lifestyle of a person that removed their prostate should feel like a male, and is there a way to prepare the national dish, so that you can have it without its deleterious effect on the prostate?
So maybe we should start off by, so I know we are speaking predominantly about prostate cancer. Initially we spoke about BPH. The gentleman asked about removal of the prostate. Can you just give us an overview as to how the prostate can be removed and what are some of the side effects or complications, or what are the expectations after a prostatectomy?
All right. So in truth and fact, so localized prostate cancer, there are two options really. Well, really more than two options, because there's an entity called active surveillance for very, very low risk prostate cancer, as Dr. McGregor mentioned, those with a Gleason score of 6 and so on. But like for majority, they are going to be like probably a 7. All right, so let's patients who have localized prostate cancer, the two main options are really surgery, what we call radical prostatectomy, or radiotherapy. And based on studies, both of them are equally successful in terms of survival rate for the first 10 years. So the 10-year survival rate is the same for the two. There are pros and cons for each. But in terms of removing the prostate, there are different ways to remove the prostate. It can be removed by robotic means, using the robot. It can be removed by laparoscopic means, and only one surgeon in Jamaica doing laparoscopic means, that's Dr. McGregor. Or it can be removed by open prostatectomy, where we make the conventional open approach and so on. But irrespective of what method you use to treat, and pros and cons for each, but generally speaking, the two main problems is control of urine and erectile dysfunction. And let's say about 40 to 60%, so an average of about 50% of men who have the surgery will have problems with erection. It may take up to 2 years for it to return on its own, some longer. But the erectile dysfunction can be treated. And the way I like to say it, that the technology that we have nowadays, once a man has a penis, we have a solution in terms of his erection. You know, so, and most of the men who will lose erection tend to be the older men, and probably men who had weak erections to begin with. But the younger patients, and especially those who have strong erection, there's a higher chance of you being in that 50% that maintain the erection.
What I also say is that, so you have two nerves that run along the prostate, and if you, depending, and this is where screening is important, right? Because if you catch it early, you can spare the nerves on both sides. So if you do a surgery and you spare the nerves on both sides, and they had normal erections before the surgery, and they're not diabetic, and they're age 70 or less, then 80% of people will get normal erections afterwards. If the cancer is starting to encroach on a nerve, and you go wide, and you have to sacrifice half of the nerve, or worse, you have to take the whole of that nerve and you're flying on one wing, then the erectile function rate drops to about 40%. But this is for men age 70 or less who are not diabetic. And it can, as Leroy said, those figures are quoted at 2 years, right? And some people will get back erections within 6 weeks, some it would take a year, some it will take 18 months, but at 2 years, that's where you call it time. So this, if you're concerned about your erectile function, the best thing you can do is get screened so that you catch it early, so that the doctor can do a bilateral, both-sided nerve spare. And then you have the best likelihood of getting back your erectile function.
Thank you.
Yes,
Question at the mic?
Yes, my question is, at what point does the doctor, at what point will the doctor no longer intervene? Is it the stage of the cancer, or is it the age of the person? Because I have a relative who has prostate cancer, he's 81, and it seems as if there's the doctors have basically said, as the doctor mentioned, it grows slowly. But he's 81 years old, and there seemed to be no interest at all in intervening. So my question is it because of his age, or is it because of the stage?
I think I would need to know more details about your uncle. But at 81,
yes,
he's already lived past the average life expectancy, right?
Right.
If he had a Gleason 6, we know that at 20 years, 90% of people with a Gleason 6 will still be alive. They may have developed spread. A certain number of them the cancer will have spread to the bone, but 90% will still be alive.
Mm-hmm.
So if you're 81 and you've got a low-grade cancer, the chances of you living to 101, right, are, not that, you're really lucky if you've lived that long. In which case, you would say, if it's a low-risk cancer, you would say, look, we're just going to watch, right? And we'll monitor the PSA. If the PSA starts to move,
mm-hmm,
or the patient starts to develop symptoms, then we would jump in and give treatment to put the cancer to sleep, mm-hmm, with hormones and so forth. We wouldn't give them surgery and subject them to that or radiation.
Okay.
You understand? So if someone, and likewise, if someone, Leroy had mentioned that, let's say you've got someone who's got lung cancer, or they've got heart disease and they have 5 years left to live,
mm-hmm,
and they get diagnosed with prostate cancer. We may say, listen, if the cancer's not causing any symptoms, right, the heart disease and the other cancer is going to take you out before the prostate cancer will. So we won't bother subject you, mm-hmm, to the treatment for prostate cancer, which does have side effects and so forth.
Okay.
Right? But if your 81-year-old has symptoms of prostate cancer and it's affecting his quality of life,
mm-hmm,
then yes, we're going to treat them. But we may not treat them with surgery and so forth.
Okay. So there'll be no surgery or chemo or anything like that, basically just to ease the pain or the suffering?
Well, what you would do is you would treat them with a medication that stops the production of testosterone.
Okay.
Because testosterone is like fertilizer.
Right.
For the cancer. It's like promotes the growth of it. And so what we do is we give medication that blocks the production or blocks the action of testosterone. And that will actually shrink the cancer.
Okay.
Right? And I have seen people who they have a scan, a bone scan, and the bone scan lights up and there's cancer all over the skeleton. You start them on hormonal treatment and you rescan them 6 months later and the scan is negative.
Oh, okay.
Right? And so the cancer will go to sleep, it will regress, it will shrink. The only trouble is it may stay like that for 5 years,
and then
maybe 10 if you're lucky. But at some point the cancer gets clever,
okay,
and learns how to dodge around the treatment and break free.
Okay. All right, thank you.
The conversation has been very engaging, but we must acknowledge the setting of the sun. So I'm going to invite Brother Mitchell to come forward. He's going to be giving us our Vesper thought. I'm going to ask our panelists just to give us a few more minutes. We're going to acknowledge the setting of the sun, and then we'll wrap up our discussion in a few. Brother Mitchell?
Could I ask one quick question?
Let me find out where Brother Mitchell is first. Yeah? Okay. So we'll take your question after the Vesper thought.
Good evening, angels. As we look forward to an upcoming new week, I just want you to open the scripture with me to Ezekiel chapter 33, and I just want you to Ezekiel, Daniel. And there's a message here for all of us about our role as God's watchmen. And follow me in your scripture, in your Bible as far as possible, because there's some high points along the way. The watchman and his message, Ezekiel 33, verse 1. Again the word of the Lord came to me, saying, Son of man, speak to the children of your people and say to them, when I bring the sword upon a land, and the people of the land take a man from their territory and make him their watchman, when he sees the sword coming from the land, if he blows the trumpet and warns the people, then whoever hears the sound of the trumpet and does not take warning, if the sword comes and take him away, his blood shall be on his own head. He heard the sound of the trumpet, but did not take the warning. His blood shall be upon him, but he who takes warning will save his life. But if the watchman sees the sword coming and does not blow the trumpet, and the people are not warned, and the sword comes and takes any person from among them, he is taken away in his iniquity, but his blood I will require at the watchman's hand. So you, son of man, I have made you a watchman for the house of Israel. Therefore you shall hear a word from my mouth and warn them. When I say to the wicked, O wicked man, you shall surely die, and you do not speak to warn the wicked from his way, that wicked man shall die in his iniquity, but his blood will I require at your hand. Nevertheless, if you warn the wicked to turn from his way, and he does not turn from his way, he shall die in his iniquity, but you have delivered your soul. Therefore you, O son of man, say to the house of Israel, thus you say, if our transgressions and our sins lie upon us, and we pine away in them, how can we live? Say to them, as I live, says the Lord God, I have no pleasure in the death of the wicked, but that the wicked turn from its way and live. Turn from your evil ways, for why should you die, O house of Israel? Sister White in Prophet and Kings, page 105 says, God delights to rescue sinners. The Lord seeks to save, not to destroy. He delights in the rescue of the sinners. By warnings and entreaties, he caused the wayward to cease from their evil doing and to turn to him and live. He gives his chosen messengers a holy boldness, that those who hear may fear and be brought to repentance. The messengers of the Lord are never to fear the face of man, but are to stand unflinchingly for the right. And this is the word of the Lord to us this evening as we face this Untried Week. O watchman on the walls of Israel, be the watchman on the walls of your heart. Be the watchman on the walls of your family, of your community. Be that watchman God wants us to be in these last days. There are movements happening in this world, and it is time we hasten the gospel of Christ so that others may hear and have the privilege to sit with us and worship with us in these times. Virgin, let us heed the word of the Lord as we stand to sing hymn 595. Brother Charles, I'm going to tell you. Trim your lamps, my virgin there.
Which one? 595?
What?
Okay. Nope. Let
be burning bright, the darkest hour is nearing, the darkest hour of earth's long night, before the Lord's appearing. Then trim your lamps, my brethren dear, then trim your lamps with godly fear. The Master's coming, draw it near, let every lamp be burning. Those thousands calmly slumber on the last great message burning. We'll rest our living faith upon his promise of returning. Then trim your lamps, my brethren dear, then trim your lamps with godly fear. The Master's coming, draw it near, let every lamp be burning. His word our lamp, his truth our guide, we cannot be mistaken. Though dangers rise on every side, we shall not be forsaken. Then trim your lamps, my brethren dear, then trim your lamps with godly fear. The Master's coming, draw it near, let every lamp be burning. Then let good works with faith appear to help the world around us. Obedience brings the blessing near when faith has firmly bound us. Then trim your lamps, my brethren dear, then trim your lamps with godly fear. The Master's coming, draw it near, let every lamp be burning.
Let us pray. Our divine Father and sovereign God, we give you thanks for the Sabbath that has passed. We give you thanks for the promise of your Holy Spirit. We give you thanks for your blessing towards us as a people. However, we pause a little longer in your presence to pray your forgiveness of our sins of not being faithful watchmen. But Lord, we commit our lives to you tonight to be co-laborers with you in this work of the gospel, O God, and to finish it These are time of ease, and we recognize we are not pursuing the course of action that we are supposed to do the will of God in these last days. Oh God, give us the grace and the strength to get this work done. Until Jesus comes, keep us faithful, we pray. In Jesus' name, amen.
Okay, I crave your patience for a few more minutes as we wrap up our conversation this evening with our two distinguished urologists, Dr. McGregor and Dr. Harrison. Before we get back to the panel discussion, I understand that our ladies have a very special token for a gentleman this evening. Is that correct? Would you like the gentleman to stand? Okay, can I ask all the gentlemen in our congregation to stand, please? Our ladies have some special tokens for us. I hope you have sufficient. Do you need more female hands? Please don't forget our panelists. For your 21 pastor. I think we need a few more hands. Okay. Daryl? Yes, we're going. Yeah, special for that. Sounds like you're getting special ones. Okay, while our special tokens are being distributed, there was a gentleman in the congregation who had a question just before Vespers. I'll ask him to ask his question, and then I'm going to go back to our panelists for their final thoughts as we wrap up our program.
Okay, my question is very short. Are there foods that we can eat that promotes the health of the prostate?
Okay, it's a bit of repetition, but I'll go back to our panelists. Are there foods that we can eat to promote the health of our prostate?
Okay,
we're gonna have the question answered.
Right. Okay. So we had mentioned earlier on that, there's nothing specific that we can say categorically based on studies that these will definitely prevent prostate cancer. But what we can say, to say that there...
Can we just tone down a little bit, please?
To say that there is food that is good for the prostate, we're saying stay away from the unhealthy food. And we generally speak by saying if it's good for the heart, it's good for the prostate. So the things that are bad for the heart, the animal fats, red meat, that sort of thing, excessive dairy. So and the refined food in general, the processed food. It is said that really the best food for us to eat, not just for the prostate, for the heart and everything, that if it comes in a tin, if it comes in a paper bag, and if it comes in a plastic, it's not good for you. So try as much as possible to eat natural stuff. processed food is what is killing us.
Thank you. Go ahead, please.
Okay, you said earlier on that duration of migration to a different environment will cause it to go up. But you didn't say if it will ever get back normal, even though it's being a prostate, but into a different environment.
Are you clear on the question? Sister, can you clarify a little bit for me, please? So you ask about migration from...
That what you were saying earlier about a person that's traveled from a different place to another environment will cause the prostate to go up. But you didn't say if it will get back normal, even though it is being a prostate still, but into a different environment.
So we are saying that if you move from certain environment to others, like they move from Japan to US, because of environmental factors, food and that sort of thing, the risk of prostate cancer increases. If they now spend some time and move back to where they were initially, will they go back, well, to the original risk or low risk level? Maybe, maybe not, we're not sure, but the fact that they would have been exposed, and depending on how long they were exposed for, they'd probably still be at a little bit higher risk than those who remain in the health environment all their life.
Yes, my sister.
A quick question. My dad is 83 and he's fully blown, he has full-blown prostate cancer. Now, a month ago, he went to the doctor and they're recommending that he does a colonoscopy. At his age, for me, I told him no. Because what you go through when you do a colonoscopy, I don't think it is safe for him. What do you think?
You said he's 83?
Yes, he's 83.
Well, as urologists, we are considered the plumber of the medical system. This is a different specialist, but at age 83, it depends on what discussion. He may be 83.
He's not strong to do it.
Yeah,
I don't think he's strong to do it because you have to consume so many water to flush out your system to go through this procedure. And he's not up there in strength for me. So I tell him no.
What I would say, sister, is that we can't give specific medical advice from the platform. But I would say that if you have a concern, you can seek an alternate medical opinion. So going to someone else. Well, yes. So you can always get another opinion.
For him, he said at 83, might as well him just finish live out the days, and when his time come, it just come.
I think I understand.
Agree with that.
I understand what you're saying.
Yes.
And it's important, right? Because you don't want to put him through unnecessary suffering. If it's not going to affect the management or the outcome.
Yeah.
But the thing is, you need to make sure that, you know, maybe they are thinking that he has colon cancer, and the colon cancer they can do something about, which will make him feel stronger and better. So it's difficult from us up here, and what I would recommend is that you go back, speak to your doctor, and ask him to explain why and your concerns, and if you're not happy with that answer, then go and seek a second opinion and speak to someone who can give you, because in order for us to give you an informed opinion, we need to know all the details of your dad. All, you know, how bad is the cancer? Is it a Gleason 7? Is it a Gleason 10? What is his symptoms? All these things, which we can't give you from the podium. Yeah.
Yes, what I want to ask about prostate cancer. If I'm diagnosed with prostate cancer, whether high risk or low risk prostate cancer, apart from doing the surgery, so I want to know that, like, if these like the pomegranate leaf or the guinea weed or whatever you eat, if that can help to kill the prostate cancer cells from the body.
So you're saying someone who has been diagnosed with prostate cancer,
yes, sir, yeah.
Whether those herbal remedies are recommended or have an effect? Is that what you're asking?
Yeah, I'm asking if the herbal remedy could help to kill those symptoms of the prostate cancer.
kill the symptoms or the cells?
The cell, I should say, right, the cell,
Okay.
right.
So or alternative treatments, herbal remedies.
All right, so most of medicine is herbal remedies, right?
Yes.
So aspirin comes from the tree, the birch tree, the bark of a tree. Atropine comes from belladonna flower.
Right.
You know, a lot of medical treatments come
Yes.
from plants.
Plants, right? Yeah.
Right?
Yes.
So we have to respect and understand and realize that plants can cure you, right? But what we don't know for a lot of these remedies is what dose do you give? How often do you give it? Does it, you know, it may work in a test tube, right? But does that translate to somewhat to a human being with the cancer?
Yes.
Right? Certainly what I tell patients is that you should go on what I call a prostate cancer diet.
Right.
Which is essentially the same diet that you would go on to prevent prostate cancer. So I say cut out dairy, cut out red meat, cut out animal fats, nothing fried, nothing out of a packet, no processed food, lots of vegetables, and exercise. What we do know is that cancer, really, the main source of nutrients is sugar, right? So there are studies which show that if you reduce the amount of sugar that you intake, that also can help you go into a ketogenic state, they call it. So, you know, it's important to, when you're treating cancer, to think of the whole patient. So not just the diet, also the exercise, and also a positive mental attitude. And studies have shown that prayer, meditation, these things also can be beneficial, right? So you know, on a whole, I would say you're not going to, you know, so long as you don't overdose on the herbal remedies, right? A lot of herbal remedies, you know, they're certainly not going to make it worse. Whether or not these are going to make a difference, I can't tell you, unless you have, you know, what we call level 1 evidence, a randomized clinical control trial, right? But on a whole, I always advocate healthy diet, exercise, and if you want to take herbal remedies, then, you know, by all means take the herbal remedies. But I wouldn't take the herbal remedies and forget about conventional treatment.
Right.
Do both. You understand what I
Yes.
mean? Treat for the worst, hope for the best.
Yes.
Yeah.
Yeah, that's exactly what I advocate and tell patients. Take whatever you're taking, but do not ignore what we're giving you. Because so often, sometimes, we do a biopsy, patient disappears for 1 year, 2 years, and taking all sort of herbal remedy by itself. And when they return, the cancer is all over the body. And then there's not much we can do then.
Okay, I get you now. All right, thank you.
Okay, thank you, brother. Brother John?
Thank you, sir. I know we're speaking on male health. I'd like to digress a little bit. Could you say something about testicular cancer? Is it possible to tell us a little what are the
Synopsis,
symptoms?
yes.
Yeah.
All right. First of all, testicular cancer. If I ask anybody here to show me a hand. All right, let me ask. Anybody here has ever seen anybody with testicular cancer? No, man, doctors don't come. Exactly. Because testicular cancer is quite rare. Even as doctors, only us is merely specialists who probably are gonna come across it. Even a lot of general doctors out there don't come across it. So testicular cancer is rare. The good thing about testicular cancer, though, that the treatment is quite good. They respond to treatment quite well. And because the testes hang outside the body, it's easy to diagnose it because most men and those who love the 21-day thing, you know, they get a lot of examination of their testes. And so it is picked up, either them or their partner will pick up some irregularity. because most of the time it's not painful. So they pick up some irregularity at the testes, they go to the doctor and they get the ultrasound done, and then we take it from there. But the response to treatment, the survival rate is like 98%. So it's very good. So to be honest, we don't have a lot of experience in Jamaica on testicular cancer because it's rare.
Thank you very much. I just want to make sure that we address the online questions. There are a few online questions that still remain. I think we have touched on some of them. One of them asks, can we get rid of cancer and how? And we have been talking about treatment modalities. Another question is there a correlation between sexual activity or having many sexual partners and the development of prostate cancer? I think we addressed that one a little earlier in the program. This question is all prostate cancerous. We address that as well. There are different conditions related to the prostate. There is a benign enlargement, there is inflammation, and there is cancer. The last question, though, we didn't address completely, although Dr. McGregor hinted at something. What about fasting to promote healing, not only of prostate cancer, but all health issues? Fasting. Anybody want to take on that one?
I can talk about that a little bit. So fasting, there's a little bit of conflicting evidence, but most of the evidence suggests that fasting is good, especially if you have high cholesterol and you're trying to deal with high blood pressure, high cholesterol, diabetes, you have to be careful with fasting, but certainly with high blood pressure and high cholesterol, and if you're overweight, there are different fasting regimes. The commonest one for cholesterol is a 16-8 fast, so you fast for 16 hours and you eat during the 8-hour period. That doesn't mean that you fast and then you go and have enough ice cream and you know, and that gives you a license to eat unhealthily. You know, you still have to eat vegetables, you know, avoid sugar and so forth. And in terms of cancer, you know, sugar is what cancer metabolizes, right? So it stands to reason if you reduce sugar intake, that's going to reduce the rate of growth of the cancer. With fasting, once you go beyond a certain time, and I think it's the 12 or 14 hour, you start to get scavenging of cells that are normal cells that may be dysfunctional. The rate of destroying those cells or ingesting those cells goes up when you're in a fasting state. So there is some body of evidence, it's not conclusive, that you turn on your body's ability to scavenge cells that have been damaged and are now at risk of becoming cancerous. So fasting on a whole it does seem to be a good thing. I don't know if Leroy has anything to add.
There has been a lot of research going on, and you go on the internet and you see a lot about fasting. And I mean, some of us just naturally fast for one reason or another, not getting a chance to eat and so on. But not just a physical fast, but I think they may also be referring to a spiritual fast. So, of course, a spiritual fast has its own benefit. It's not just looking at the physical benefit, but the spiritual benefit. And we know the interaction between the spirit man and the physical man. So yes, I endorse everything, but also a spiritual fast would be even more beneficial.
Thank you very much. So we have had a very engaging program this afternoon. We have received a lot of very good information from our panelists. And in wrapping up, I'd just like to give each panelist a minute. If you had a parting message to our congregation and to others online, what would you tell the persons listening to you? Starting with you, Dr. Harrison.
Well, as we said, prostate cancer, especially in Jamaica, it's the #1 cancer, both in terms of its prevalence and also in terms of being the #1 cause of death. And in Jamaica, we still advocate that we do early screening of prostate cancer, because when prostate cancer is advanced, there's very little we can do about it, and it's quite costly in terms of treatment. So early detection, and then with discussion with your doctor, you'll decide whether that type of cancer needs intervention or not. Because in its early stage, we're able to treat it, and the success rate and survival rate is quite good, and you may be able to live just as a person who never had prostate cancer any at all. So don't be fearful about doing digital rectal examination. If you're fearful about that, at least go and do the blood test, which is not only available through private institutions, but all government institutions offer PSA testing.
Thank you. Dr. McGregor?
When we are born, right, we're given like a car, for example. You're given this body to drive. And unlike a car, you can't replace it. You only get one body, right? If your car pop down and it gets really damaged, you can upgrade. You only have one body. We're born with one body that we have to drive around in every day for the rest of your life, right? And it is precious. And so can you imagine that you put crap into this car, into this machine? You're gonna put, lots of sugar, which causes distress. Alcohol causes distress. Oily foods. You want to look after your body, your car. You're going to service it regularly. You're going to put 90 petrol in there. You're going to go and take it to the, and get it serviced at regular intervals. That's like your annual checkup, right? So, look after it. It's very precious. It's the most important thing that you're going to have. And you want to enjoy it. You want to respect it. And you want to make the most of it and let it serve you for as long as possible. So that is my main message to everyone here.
Thank you very much. And just to show our appreciation for these gentlemen, can we just put our hands together? Thank you very much. I think Dietary has 2 tokens. And outside of this setting, if we need to see these gentlemen, I get one too? Oh, thank you very much. If we need to have detailed conversations with you gentlemen, where can we find you, Dr. Harrison?
Either publicly at Kingston Public Hospital or at Kingston Urology on Hope Road.
Okay, thank you. And Dr. McGregor?
I'm at the physician's offices here at Andrews Hospital.
Okay, thank you very much. So once again, thank you very much for coming to Andrews and being part of our program. We thank you for all the important information that you have imparted. And I'm hoping that it actually causes behavior change within our men. And for the women that are here, I hope that you go home and you insist that your husbands and your brothers and your sons go and get themselves checked out and not wait until things are too late. Thank you very much, everyone. Remember that this is only part 1. Part 2, we're going to be talking about sexual dysfunction, erectile dysfunction. That date will probably be in the new year. And we're also going to have a men's clinic, which is focused on men's health. So you'll be able to come here. We will have various doctors, including urologists, and you'll actually be able to consult with these persons about your health one-on-one. Thank you very much, and have a wonderful week. And we will see you here again next week, Sabbath. Thank you very much again. Bye-bye.